Thank you. Thank you, Medinosa, for this kind introduction. Unlike previous speakers, I'm no genetist. I don't deal with specific technologies. I'm somebody working at the hospital. I have 55 patients. I visit somewhat like 2,000 patients on a yearly basis. I work in the hospital and I only see patients. So whenever I go to a room, I can meet somebody with a disease. The disease could be heart decompensation. This is usually the case, or could be diabetes or cancer or atrial fibrillation or a few of the above pulled altogether. So whenever I see my patients, my first question is as follows. Do I have to treat this gentleman or this lady as I would treat the lady or the gentleman next door that is affected by the same disease? Do I have to try and look for the same signs and symptoms? Do I have to use the same diagnostic tools, X-ray, ultrasound, CT scans? Do I have to administer the same drugs? No, this is 2015. We're talking about precision medicine at this conference. Yet there are scanty data in the literature to answer these questions. We can rely on very little data as to gender differences. And whenever such data exists, the result proves that the differences are quite relevant indeed. As a matter of fact, all what we do, what we teach, and I also am a university professor, is based on trials carried out on male-only trials, again, all male-only investigations. So you might think that I'm going to talk about women, but as a matter of fact, over the past few years, both at EU level and in Italy, many attention was focused on subjects that only affect women, for example, papillomavirus, cesarean section, breast cancer. But what I'd like to highlight here today is that gender medicine or gender-specific medicine is not just based on women's health, because gender-specific medicine is something completely different vis-a-vis what we've been used to date. Gender-specific medicine basically devotes a lot of attention to the different stages of life, even within the uterus, in the second, third, fourth stage of life. On the far right, you see my patient from Sardinia who turned 112 recently. And the gender specific basically should devote attention to both patients and diseases. I am no specialist of gender medicine. I believe that this is a new dimension that should go across all the different aspects of medicine, studying the impact of gender on physiology, how diseases are triggered, on physiopathology, on pathology. And as I just said, gender-specific medicine is based on the fact that far too many trials describe diseases only focusing on series made up of men patients. Here there are many men, and whenever I say such things, they ask us, what do you want from life? We live long. Women, we live longer. And this is the Italian statistics. And as a matter of fact, life expectancy at birth is nearly 80 and over 80 for women. So you see that the gap is being bridged. You see that men's life expectancy growing and not so much women's life expectancy. This is another similar aspect. That is, when I turn 50, what is my life expectancy in terms of healthy life expectancy? This is Lancet 2008 that published this trial. In Italy, for example, a woman of 50, or actually a man of 50, can have a life expectancy of 30. In the case of a man, 35. But if I look at the life expectancy in terms of healthy life expectancy, you see that this remains unchanged, always 20 for both men and women. This means that the increase in terms of life expectancy are years of life that women have to live in a situation of disability and sickness. Apparently, this is creating quite a lot of reaction. Well, this is not the kind of old age that we expect as women. So together with precision medicine, I think that there's also a strong urge to understand that precision medicine for women is something different than precision medicine for men, as is the case for all medicine. I'm now going to present some cases on heart and disease, osteoporosis, neoplasm, disability, arthrosis, depression, and dementia. As to heart disease, which is the most important lethal disease for mankind, well, you see that in that case, the mortality for heart disease is including stroke and infarction, diminished between the 70s and the year 2000, especially with men. Men indeed are proved to be very reactive to the different campaigns that were launched throughout the 70s, 80s, and 90s. Whereas in the case of women, women did not react similarly. As a matter of fact, they just started reacting to the campaigns of late. So the conclusion is that heart and vascular diseases over the past 30 years haven't diminished in women as they have diminished in men. And have a look at this slide. The problem is quite important. As you see, this is again the Italian statistics body, and it points out the main causes for death. And in man, it is heart and vascular diseases, and the same for women. So you see that with women, on the right-hand side of the slide, heart and vascular diseases cause 10% more deaths. In the case of women, things have a worse outcome when the veins or artery are poor. For example, intra-hospital mortality after infarction are worse with women. And survival at 6 months away from infarction is higher with men if compared to what happens with women. And again, mortality at 5 years after the implant of a bypass is higher with women. As Mrs. Kennedy just said yesterday, actually she reminded us, infarction is case number 1 of death for women. And if you analyze life, well, there actually more women were affected by heart infarction than men. Yet heart and coronary disease is apparently more aggressive with men than women. Now, this is something that is a false belief. How basically did we get to this point? Well, over the past 40 years, medicine has been somewhat rewritten. Many papers were published, and some of them identified the main risk factors. Hence, the preventive action required so as to be protected vis-a-vis heart and vascular diseases. In the case, a lot of women were studied. Actually, no women whatsoever was included in these trials. This is the first paper including statins that was started in the 90s and was concluded 5 years afterwards. And no women were included in this trial. Then, if we look at treatments, well, earlier on I showed you trials on prevention. This is on treatment. Well, cardiovascular disease, again, well, if you know anything about statistics, you probably know that when there is such an imbalance in the groups, it means that the results are certainly, the outcomes are certainly very poor. These investigations, these trials lie at the basis of our guidelines. As physicians, sometimes we are even tried at law based on these guidelines. With women, things are very different. For example, women do not show the same signs as men. So what we are taught during the medical school is not what happens with women. So you see, this is what the handbooks of medicine is telling us, like, you have to see whether the patient feels a pain at the sternum, at the chest. As a matter of fact, women do not feel pain. The younger she is, the less pain she has, or sometimes she has maybe some back pain or some tummy pain, or sometimes she can perceive some anxiety or some shortness of breath. Oftentimes women, up until recently, because then cardiology made important steps forward, but up until recently with myocardial infarction, she would be admitted to psychiatric ward and not to cardiological ward. So the signs are atypical. The age of onset is higher. Usually they have estrogen, and so they are somewhat protected by heart diseases. But the atherosclerosis may be more recent, but the plaque are younger, and the situation is such that less the more recent lesions are caused with women, but more dangerous as well. Another feature with women is that women usually have problems not with the large arteries, but with the micro circulation. So there could be, for example, negative exams. Sometimes there is one vase coronopathy. Sometimes there's disorder at the pump that is more severe with women than men. And with women, oftentimes we have malignant arrhythmias, so we have tears, we have coronary dissection. And if we look at these three different diseases, in the case of heart rupture and coronary dissection, well, they only happen to women, not just women, but these diseases, and this has been known for decades, that only affect women. And why is that? Why over the past 50 years we've learned about that, and why haven't we studied why that is the case, why these diseases only affect women? There are certainly many delays also, or there a long time between signs and diagnosis, and treatments are different. When women are sick with such diseases, they are less treated. We know that women go more often to the physician, but the woman with diabetes, for example, is less treated with ACE inhibitors, with aspirin and other drugs than the case with men. So women go to the doctor more often, but when she is sick, she is given less drugs. And this is certainly confirmed also by data collected in 2015. Then women undergo less less coronary coronography, less PTCA, less stent, less bypasses, irrespective of age. But you might think that we get too old, and so that we are not administered the same treatment. But this is not the case, because this is true again, irrespective of age. So even with early women, I'd like to refer to stroke. Well, the stroke risk is 55% higher with women than men. The most important risk factors with women are hypertension, diabetes, atrial fibrillation, overweight, tobacco smoking. And I'd like to highlight that because there's a paper that was published in 2014 stating that the damage caused by one cigarette in women is equal to the damage caused by 5 cigarettes with men. So the noxious potential is much higher with women than with men. And then obviously family history, lack of exercise. Last year, a very important meeting was held. In October 2015, there was the World Day against stroke, and that was devoted to women because, again, women are worst affected. Let's look at what happens in the case of a man who is neglected. This is a paper that we published in the Veneto region as red stands for osteoporosis and yellow for osteopenia. You see that after 40 years, down to 70, 79, you see that there's a lot of osteoporosis and osteopenia with women, but nobody had actually carried out the same trial on men. And you see that also men develop osteoporosis and osteopenia because usually these trials do not include women. Many realize that mortality for all causes for man is, for example, the fracture of the femur. And this is true for man. So after a fracture, the mortality for man is higher than with women. Gender differences in the biology and morphology of bone can have impact on the physiopathology, on the drug selection, on the identification of the skeleton implant. But to date, men are less treated, and no difference exists between treatment for men and women. Most studies on osteoporosis were carried out from 1980s onwards and only on women. And I would like to know whether any male in his 60s and 70s years underwent MOC, and how many drugs are men administered. You know that most drugs given for osteoporosis are not tested for man. And when I perform a densitometry, a bone densitometry for man, what are the values that I should consider as regular when all the bone when all data have only been published only for man? So we may perform tests, but we don't know what the normal level should do. So you see what happens again in the lack of gender medicine. Let's have a look at cancer. Well, in Padua, the first Italian Congress was held on gender oncology, and it was the first World Congress on gender oncology. In the case of lung cancer, you see that mortality between the 80s and year 2000 increased by 600%. Adenocarcinoma is the most frequent lung cancer. It is cause number one of tumor death. So this is not the first. It is the first disease causing death, not the most important type of cancer. With lung cancer, well, we've learned quite a lot with women. We know, for example, that the carcinogenic element of tobacco for women act differently. We know that tobacco smoking is more hazardous than with men. And there are trials referring also to the association between lung cancer and papillomavirus. With women, there is a higher reaction to the KRAS. Unfortunately, I cannot dwell on that. And women react also most effectively to cisplatin and to a best prognosis when they're affected by lung cancer. A negative role is played by estrogens and estrogen receptors and the lung cancer. Usually those who administered estrogens, even hormonal replacement treatment, usually see a reduction in the colon cancer by some 35%. But in the case of lung cancer, actually the opposite is true. So how do we feel like raising issue? Do we have any indication at the clinical level? What do oncologists do? And are we teaching such differences to our students? And again, is there any adequate prevention? Well, for example, I see that many young, very young women smoke. I see that tobacco smoking is ever more disseminated and popular among young women. Then I'd like to refer to the cancer of colon rectum. This causes death 5 years after men. So basically, their death is postponed. If compared to men mortality after colon cancer. The problem with women is that women tend to have more ascending colon cancer. This is not 100% true, but usually it is the ascending colon that is more seriously hit, whereas the descending colon or the rectum is more seriously hit with man. Does this mean anything? How come that ascending colon is involved with women? Does it have any impact? It entails that the cancer stays silent for many years and then it becomes patent as an emergency because there's an occlusion. But the problem is that this cancer for all too many years doesn't create occult blood, which is our basic screening, which is widely disseminated across the country. Usually we'll go look for occult blood, but occult blood is not present with the ascending colon cancer. So wouldn't be the case perhaps to change something also in terms of prevention? Shouldn't we change the screening program? Shouldn't we change the treatment? I'd like now to go back to something which is often neglected when it comes to man. Well, depression is often neglected with men, so much so that our diagnosis patterns with DSM-4, well, these are not adequate for man. As a matter of fact, depression in man is profoundly underdiagnosed. And this is clearly visible if we consider that suicide is much higher across the world. So many more men commit suicide compared to women committing suicide. Another sickness diagnosis, arthrosis is a very severe disease, and you see the gender differences. You see hip arthrosis, for example, is affecting women twice compared to men, and the same is true for hand arthrosis. So arthrosis basically has a much higher prevalence on women. Earlier on I was saying that we live longer, but there are three main diseases making women disabled, i.e. the consequences of cardiovascular disease, cognitive deficit, and arthrosis. We don't quite know whether this has to do with hormones, or whether it has to do with genetics or functions. We know nothing about what explains these differences. We know that arthrosis is a problem which is bound to grow. This is a projection till 2025, and arthrosis is always going to be prevalent with women as against men, and very little is done to carry out in-depth studies on arthrosis and its consequences. You know that the world is aging, and this is true everywhere, and I think it would be most important to carry out these trials as soon as possible, so that longevity doesn't coincide with disability, especially so with women. Now I'd like to refer to dementia, and then I'll be done. The prevalence of dementia is here shown. You see that the gray line is tilted upwards. These are data from China, but as a matter of fact, these are also US data. and this is the Framingham study, and you see the risk to develop Alzheimer, and you see that at different ages, men run twice as much the risk to develop that disease. These are Italian data. Here they go. Perhaps you can't read the dotted line. Still, that is a line for women. This is a Conselice trial that analyzed women up until 95 years of age, and you see that between 65 and 95 there is an important increase of dementia and a much higher prevalence in women than men. Being women is a risk factor for dementia. The risk of women to develop Alzheimer is twice for women than with men, and hormonal and genetic differences between the different genders contribute to this increased risk, and it is not the increased survival of women that plays a role there. Obviously, women do live longer, but that doesn't have anything to do with the fact that, again, we develop Alzheimer's much more often, and that also we develop dementia much more often than men. And then usually it is out of 10 cases you have women looking after a patient with dementia. What has happened over the past 50 years? Very important discoveries were made. I got my degree 43 years ago, and since I got my degree to date, well, I believe I had to do away with what I knew and to write everything again, or to learn everything again. In the US, they say that women were studied only for their reproductive system, i.e. ovary, uterus, and breast. The rest of the human body has been taken for granted, actually has been considered as equal to that of man, which is not the case. The most important journals, scientific journals, Nature, Science, and so on and so forth, they are urging us to focus on gender-specific issues. This box states medicine today, when applied to women, is much less based on evidence if compared to the medicine developed for man. I talked about osteoporosis, and I must tell you that there are not many more studies available in the literature comparing men and women. In many areas of medicine, men were studied as if they were the normal element in the human species. There are no sufficient data that can tell us that we can have an evidence-based medicine, including women, at a time of important scientific discoveries. We just learned about the important developments that we're going to see in the future. Well, I believe that we should start granting women gender-specific medicine. So gender-specific medicine is a new emergency of this new millennium. And let me conclude showing you two final slides. One is just for you to understand what gender-specific medicine is not. So it shouldn't just study the diseases that affect men as opposed to women. The New England Journal of Medicine are publishing trials based on data that have been there for years. So we don't have to study women just because of the reproductive apparatus. We don't have to have the pink ribbons because they are not good for much, and we don't have to have a specific gender medicine wards, or we don't have to have specific physicians. We don't have to have new trials on men as opposed to women. And I think that we don't need anybody teaching gender-specific medicine. Well, I do teach that, but I believe that my job is just to trigger a new process. I think that there should be a way in the next 5-10 years, because we don't have to teach in the medical schools anything but gender-specific medicine, which entails about starting from scratch, going back to the beginning, so describing also the differences in terms of bodies and organs between men and women, identifying the differences in the physiopathology of diseases, describing also the clinical signs that are quite different when it comes to men and women. We should also assess to what extent a diagnosis is effective, to what extent a treatment is effective, to what extent a prevention is effective, because in the diagnosis for a woman when she's affected by heart disease is different, and the drugs administered to a woman should be different. So protocols should be developed so as to include women. And I believe that, again, all medicine should be focused on gender-specific medicine, so it shouldn't be just something isolated. I refer to the fact that gender-specific medicine doesn't have to do only with the health of women. I understand there are many young people amongst you. I want to say that the gender-specific medicine is not just for women physicians. This is rather something that basic science and clinical medicine owe it to the world. Having said as much, I'd like to thank you for your kind attention.